Welcome everyone to our episode of Go Live by the AMIA Clinical Informatics Fellows. And we have with us here two members of AMIA's Public Policy Committee. And we have Dr. Joseph Kannry and Reva Singh, who is a lawyer.
So I'm the chair of the Public Policy Committee till the end of December. Then I'll be past chair. We have an excellent chair coming in called Dr. Call. I'm not sure he's a doctor. Take that back. It's Call Johnson. And I'm also lead technical informaticist for the Mount Sinai Health System at Mount Sinai in New York. New York.
Hi, I'm Reva Singh. I'm AMIA's Vice President of Public Policy. I am a lawyer by background, but I am not AMIA's lawyer.
Awesome.
Anything I say represents either AMIA or myself. It does not represent Mount Sinai.
Good disclaimer. All right. So, some of the things I want to learn about the Public Policy Committee are, what are the legislative priorities of AMIA?
Sure. So I can go ahead and get started here. I would really phrase it as the public policy priorities of AMIA, because there is overlap between, what's going on in legislation and what's going on in regulation. But our public policy priorities for 2023 are really focusing on AMIA's public policy principles, which are on our website. There are currently 9 principles, but this document is a living document. So that means it can be updated as relevant issues arise, or as issues fade away. So you can see in the document that, it was published in 2019, but it was updated in 2022. So these 9 principles, I would say, really guide our advocacy. Specific topics that are big in Washington, D.C., that, overlap with our priorities are things like telehealth expansion, ensuring whole of person care and understanding social determinants of health and how that affects healthcare access. Advancing artificial intelligence such that it doesn't reinforce systemic bias, and reducing clinical burden across the healthcare spectrum.
I would add, our priorities also include, because I think this is coming up more and more, should there be a HIPAA 2.0 for commercial entities? Government and, healthcare entities are under strict regulations, but it seems like the barn door is open commercially. And I think I think we've seen issues already around, and I know it's politically loaded, on abortion, with the question of, well, if a commercial company is collecting information on, attempts to get pregnant, cycles, etc., what protections are there? If this was government or hospitals, there are clear protections. If dealing with commercial companies, it's not as clear. I think CMS is trying to scope out a national provider directory. I think we're very interested in that. It's not clear if they have the legislative legal mandate to do so, and their need to better understand patient-provider attribution. I think AMIA in general, as in addition to the principles, is interested in anything that strengthens the informatics workforce, whether it be providers, physicians, nurses, degree students, including PhDs and masters. But I would particularly say, and I'm not speaking for all of AMIA, that there's a real issue funding and supporting the workforce of providers and clinical informatics fellowships, and that is something that.
And you mentioned that there isn't any new legislation for funding on the horizon, and it's tough because there isn't a clinical revenue source for informaticists.
No, the issue is clinical informatics fellows, and again, I'm talking about, in this case, physician providers, is unlike any other fellowship that providers go through, or almost unlike any other. In other words, if you were doing in fellowship in general internal medicine, or if you were doing a fellowship in cardiology, you're bringing in clinical revenue. It's clear the entity, CMS reimburses, et cetera. It is not so clear with clinical informatics fellows. And clinical informatics fellows undergo 2 years of training in ACGME program. They take boards in it, and they can make a big difference in how healthcare information technology is implemented, but the support for it is thin right now across the country. And there's no legislation to further fund HIT systems across the country, like meaningful use. One could argue whether there should be. There's no attempt to fix this with pharmacies. There's no attempt to fix this with skilled nursing facilities, SNFs, et cetera.
Absolutely. And I know you mentioned the importance of adding information about bias in AI, and suggesting that there be labels added for population and training to determine, is one group's algorithm relevant to another group. And I think that's really important as well.
So artificial intelligence is an area that has become a priority for us for 2 reasons. One is for a couple of reasons. One is there's a real possibility of bias, that the system could come up with conclusions that are either racially biased, ethnically biased, or biased against some group of patients. In our paper on adaptive CDS, which came out of our public policy retreat right before the pandemic, I think it was 2019, we identified the need to start labeling these things to tell us what are the training sets. The training sets affect AI. AI is not a magic black box. Are the training sets up to date? Papers have also pointed out these things. And then teaching, are they relevant in your hospital? Is there anything to watch out for? And some of this is in our AI principles as well. And we need to be training and educating the providers and, clinical of tomorrow to be able to read these labels. Because otherwise we're going to have the AI system recommend you discharge them and nobody will know why.
Absolutely. And I love how many resources are on the AMIA Public Policy Committee website, including the principles that we spoke about, and the Washington download, the bi-weekly newsletter, for members to stay up to date on activities going on the Hill. And that's a great way to stay informed for the current conversation. And then Reva, you mentioned other ways that AMIA members can get more involved. Can you tell me more about the RFIs and how you respond to those regulatory RFIs, which is requests for information?
Sure. Yeah, so staying informed is definitely the number one way to start getting involved. And the Washington download will often include notices of RFIs that we think could be relevant to folks. So, an agency will release a request for information, RFI, or a proposed rule that AMIA often responds to, but sometimes there are ones that come out that we're not totally sure it's relevant to all of AMIA membership, so we may just put the notice in the Washington download. But basically anything that's published in the Federal Register is open to public comment, including if an agency puts out a final rule. Final rules don't solicit public comment, but folks can always reach out to the agency about them. So, RFIs and proposed rules are when the agency is soliciting information from the population, and they are open to the public. So individuals can respond to them if they wish. Sometimes that can be tricky. For example, CMS recently released a proposed rule on interoperability and prior authorization, and that proposed rule is 400 pages long. So I could see how an individual may not want to read that whole thing and figure out how to respond. AMIA is responding to that proposed rule, as are many other stakeholder groups.
So it sounds like you have a lot of fun bedtime reading that you are accustomed to.
Oh, absolutely. It definitely can put you to sleep for sure. But no, it's great when stuff like that comes out, because those are such high priority topics, and can have such a huge impact on informatics and across healthcare. And when it comes to a rule like streamlining prior authorization and trying to use interoperability to do that, that's informatics bread and butter. Like, that's informatics expertise. So we do respond to RFIs and proposed rules like that. But individuals are welcome to as well. And if AMIA members, are ever seeing a topic that is of interest to them and they're not sure if AMIA is responding, they can reach out to me or other members of the Public Policy Committee and ask. We love that kind of member engagement. It helps really inform us on what does the broader membership care about and what are they invested in, and making sure that we're staying on top of that.
Very cool. And I had no idea that all regulatory agencies from the government are required to go through this process of notice and comment. So that is really good to know.
They are required to go through notice and comment for proposed rules, if they want to change or update a regulation. However, they are not required to read all of the comments that they get. So just a disclaimer that, it's worth still getting your voice out there, just like it is in any process of democratic government. But there's no guarantee that your voice will be put into the final rule.
Understandable, yeah. And then it sounds like the Public Policy Committee also reaches out to regulatory agencies and loops in the AMIA working groups when it's appropriate, and sometimes even provides expert or witness testimony. That's all very cool. I also saw that, from a legislative perspective, the Public Policy Committee can respond to or endorse specific bills, or if you want to propose a bill, you can find a congressional champion and work with them. So what has that experience been like?
Absolutely. So I will speak to my sort of background in the policy space. I've only been with AMIA for 3 months, as a disclaimer. And Joseph, of course, has much more experience with this, with the Public Policy Committee. But on the legislative side, bills we're staying informed. That's the Public Policy Committee or the Public Policy Department's job, right? Staying informed on what's coming down the pipeline. So we're staying informed to try and know, what's Congress talking about this year or this session. And, are there bills that are relevant to us that we may want to weigh in on? And basically, we can just reach out to those relevant staff. Those relevant staff are, open to discussion with the public. That's part of their representation. So we can reach out and talk about particular bills and ideas for bills. If there's something that, an office is really interested in. Everybody's interested in telehealth these past few years. So let's say they're really interested in telehealth expansion. We can go in and talk to them about, how to draft a bill that we think would be most effective using telehealth. But we can also endorse bills that are released. So the Improving Seniors Timely Access to Care bill that was released a few years ago, and AMIA endorsed it. It focuses on streamlining prior authorization. It's a very, very popular bill, and AMIA, along with many other stakeholders, are supporting it. So that was one that we're in great company on, and hopefully we'll move forward soon.
Awesome. And I also heard about the bill from this past August the Inflation Reduction Act, which gives Medicare powers to negotiate drug pricing, and kind of like playing a role as a pharmacy benefit manager and having some control over the choice of the drug formulary. That was another example of a bill. And previously, it seemed like private vendors had the upper hand on that, and Sure Scripts plays a big role
So I want to
as
jump in
well.
on a few things to go back.
Yeah.
So first, the comments that we give to agencies, they're not ignored. There's a couple of things to think about. One is look at meaningful use. If you read stage 1, it's a little harder in stage 2 and stage 3. You'll see they respond to comments. It's almost a back and forth, and sometimes it's an angry back and forth, like, what are you thinking? Or if you read the FAQs, we do not mean this. Please do not interpret this to mean this. We saw this with 21st Century Cures, where they made it really clear it was physical harm, not mental or emotional harm. The second thing is when the comments are submitted, whether they're by AMIA or by individuals, there are a few non-starters and there are a few things that always are seen as helpful or incorporate if possible. So if you basically come back with criticism, you shouldn't be doing this at all, and legislation has been passed, that's a non-starter. That's just a rant and a rave, like, something, stop what you're doing. This is the stupidest idea we've ever heard. Also, if you're basically knocking most of the premises of what they heard, if you've got something to say, how can you make it better or help them avoid mistakes? If you're not going along those two pathways, you're just writing an angry, the equivalent of an angry tweet.
So it's a combination of that informatics knowledge and the
Yeah.
critical thinking.
Yeah.
And sometimes, like you mentioned, with meaningful use, sometimes those policies were put into play before there was even an infrastructure. So
No,
it was
that's
almost
true.
like an experiment in some ways,
Well,
because there was no other option.
yes and no. So they had informatics experience and science, and it informed stage 1, less stage 2, less stage 3. They also had health policy folks on there, and they wanted to keep stretching to the point that I don't know the literature supported it. The second thing was they did say, and any informaticist disagrees with this, clearly it's in the it's in the hundreds of pages. It says implement first, figure out process later, which anyone who implements knows is wrong. It fits with what what you said, that wasn't. And third, you're right on the infrastructure piece. They did not have lab pharmacies or other key pieces of data, which is put the EHRs out there. And let's hope we have big enterprises and they have the data. And there are things we're still suffering with pharmacies today. The other thing to keep in mind that is a challenge for, AMIA members is if you go to try to talk to someone on the Hill, we haven't done that in a while as a group, you're going to talk to whoever's from your state. If you're from a small state, you're going to get the red carpet because there's only a few people coming and going. If you're from a big state, you might not. And Reva alludes to the fact that staffers are the ones who really make the legislation. It's not the talking heads on the news, meaning they have things they want to get done. They have broad principles, they have ideas. But if you want the specifics, you want to make a point, it's not to that person.
Absolutely.
It's the staffer.
And speaking to the state government point that you mentioned, an informatics topic with regards to that is the state health information exchanges. I always wondered, why isn't participation federally mandated for all clinics and hospitals? And then I learned that the federal government cannot mandate state governments. And so some states don't have any HIEs and some states have multiple HIEs, and the research is still ongoing about the utility of HIEs, and I wanted to ask your opinion on that as well.
That's a really important point. But it applies to non-healthcare as well. The federal government cannot override states. So if states have more let's say, severe or more, stringent regulations, the federal government can't overwrite that. The federal government can't write that, there are limits, and that's what's confusing to people. So one of the, limitations is in HIE. One of the limitations was in why can't we fix our public health system? Because states and local municipalities control large portions of that. That's the way the government's designed. It's beyond AMIA's ability to fix that or whether it should be fixed. It's what's in the Constitution. It's federalism versus states. I'm not trying to take a party line of either party on that, but so
Absolutely.
there are times where you're like, why can't the federal government fix it? They can't. The federal government's biggest power is they fund the biggest payer in the United States, CMS.
Yeah. And getting back to that, so which federal institutions do you most frequently interact with in your work?
ONC, AHRQ, NLM, NIH, I can't,
CMS,
CMS, yeah. Sorry about that.
HHS. Okay.
HHS, not as much HHS as arms of HHS.
Okay.
Reva, am I missing any?
That was
I'm sure I am.
really, that was good. It also, as opportunities arise with other offices, so, those are ones that we interact with most regularly. We have regular meetings with some of those agencies just so that we can keep each other in the loop on what's going on. But, as opportunities arise from other agencies, or, congressional committees, we're still aware and keeping track of that.
See. Okay. And I think you mentioned,
Yeah.
Reva, some of the work you're doing with the VA. Could you tell us
Yeah.
about that?
Sure. So, AMIA is working to propose a informatics SOC code, a standard occupational code, that comes from the Bureau of Labor and Statistics. But we have been working with members in the VA who are AMIA members to, start this get this proposal together for the next cycle, basically, to make sure that we have as full proof of a proposal as we can, that we submit to the Bureau of Labor and Statistics. So right now we're working with the VA because as AMIA members, they brought this issue to us. But as we finalize this draft proposal, we will be working with other stakeholders as well, just to make sure that it's as comprehensive as possible before we actually submit.
Awesome.
This
So
is the
that's
occupational code, right?
Yes.
Yeah, no, this has been a source of, this has been one of the things where we've felt passionately we are not being heard. And part of it is there are other bodies and other competing organizations who would argue we are informatics, ignore this.
So, and this is for the purpose of strengthening informatics jobs and salaries from
Yes.
a VA standpoint. Okay.
Well, from an AMIA standpoint too, just making sure that, folks who are trained in informatics or specializing in informatics, they're not getting the same sort of credit or support or resources as other medical specialties. And it's a specific kind of expertise. So not everybody who works in medicine is an informaticist. And so, trying to really leverage that.
It's important
Basically,
because HR departments don't know what to do with it. So
right. How do we recognize this new field of medicine? Okay. Gotcha.
I can tell you we have informaticists here. We have lots of people doing it, but we have had challenges with HR hiring a new informaticist because they don't know how to code it. They don't know how to compare salaries. They don't know how to compare it to what.
Okay, yeah. And so another thing that general members of AMIA can do, Reva, you mentioned that we can submit grassroots templates for high impact. Can you give an
Yes.
example of that as well?
Yes, so actually in my time since we've been at AMIA, we haven't done a grassroots campaign. However, we do have plans to do them in the future. So those will be available, you know, as I said, staying informed on what's going on with AMIA through our website and things like the Washington download is really helpful because it will have those opportunities available in them. So, you know, if we have a grassroots campaign that we're pushing out on a specific topic, basically AMIA will put together a template for AMIA members to submit on whatever the issue is. Typically, grassroots campaigns are done within a set amount of time. That's not always the case, but often it'll be something along the lines of, this bill is going for markup in 2 weeks or next week. So we want to put a grassroots campaign out today, you know, promote it to AMIA members so that they know they have a week to submit this grassroots template that we draft out for them, but they could fill in, you know, personal anecdotes on. So
Perfect.
please look out for things like that. They can be going to Congress or to agencies, both accept grassroots.
And the Washington download, is that sent as an email newsletter that people can sign up for?
I do believe people can sign up for it. It is also archived on our website, as Sanah showed earlier in the video, so you can always find it there. Other popular places are the e-newsletter that goes out, and yeah, just the public policy web pages.
Awesome. And which congressional committees have jurisdiction over healthcare that you interact with the most as well?
Sure. So to Joseph's point, if we, you know, go to the Hill, then we will bring our members to see their representatives in their state. But we also keep track of 4 major committees that have jurisdiction over healthcare, and that's House Ways and Means, House Energy and Commerce, Senate Help, which is Health, Education, Labor, and Pensions, and Senate Finance. So those are the 4 committees we work with most closely and, you know, keep closest track of, but sometimes there are representatives who aren't on those committees that are invested in healthcare or informatics topics that we may also be interested in.
Great, so those are 4 to keep an eye on. Awesome. Because they usually propose and pass healthcare legislation. Great. And then I wanted to ask about which areas of medicine do you feel we can establish more data standards, and what can we do to standardize EMRs further? Do you think there's any role for legislation in those areas? I do remember that in 2011 there was a bill suggesting standardization of EMR interfaces, but there were concerns from one group that they might stifle innovation. Restrictions might stifle innovation. Wanted to find out if you agree with that, or if the times have changed since that 2011 bill.
I think it's a very complex topic. If I was running things, which is not going to happen anytime soon, or should happen, I would basically say we should have one EHR and each vendor should build what they build best as modules to it. That's not going to happen. I think if we're going to talk EHR standardization, we do need to realize market share. I won't use the vendor's name, but one vendor does dominate the market share, and not do a pretense like, well, Microsoft doesn't exist, so we're not going to, the equivalent, we're going to pretend we're not going to build to Windows. I think the EHR standardization that is finding challenging is there are some things in US CDI and other areas about capturing concepts and the way we're organized to present care. It's been a problem in the directories, you know, the attempt of CMS with the directories as well.
And what is CVI?
I'm sorry.
What is CVI?
I meant US CDI.
Oh, I'm sorry. Okay,
Yeah, USCDI. I'm sorry if I mispronounced it or spoke too quickly.
okay, you're talking about the core data for
Yes,
interoperability.
yes,
Okay,
yes, the US core data for interoperability.
okay,
So for example, they're trying to capture providers' practices too, and if you don't understand that, you're gonna have problems connecting things.
yeah,
Health information exchanges have come a long way, but the test is how easy is it to use in routine care? You have one vendor which does dominate. It actually works very, very well within that vendor across 70% of space. It's got to work as well within the 30%. I don't think there's a desire or the ability to, to legislate all EHRs need to look the same and work the same. I don't think it's possible at this point. I do think we need to do more usability testing. We need to understand the role of scripting and testing. We're doing research and publication in that area outside of the policy committee. Because if you're not testing the same things and not looking at the same things, how are you going to standardize it? Someone thinks it should be red button in the upper right, and someone thinks it should be a green button in the lower, and it becomes a light beer debate on this should be the way it functions,
yeah. And what do you think medical societies can do to translate those clinical guidelines into CDS? Because it seems like right now, some of that language you mentioned
I
is
think
not very definitive, like consider doing this or use clinical judgment.
I think they need to start thinking, what will this look like when it's computerized? And we wrote a paper, the first author is Tom Schneider. We discussed this in that paper on genomic decision support for the Ignite Consortium. And I think the concept is really simple. Is it human and computer readable? Computers do not deal right now very well with vagueness or heuristics. And when an agency, when a body, a professional society comes up with a guideline, they have to ask themselves, do they expect it to be computerized? And if they expect it to be computerized, is this something that makes logical stepwise sense? And sometimes they don't do it because the evidence isn't there, but sometimes then they're asking why nobody's doing it and why nobody's put it into an EHR. You can have, the work of Rick Shippen many years ago. I trained at Yale Center for Medical Informatics, showed, there were guidelines that led nowhere. They led to a decision. There was no decision. You can't have something that says, well, you should get an aspirin, all patients, who've had an MI, but, please evaluate the clinical situation. A computer can't do that,
Right, it
even
can't be
with
plugged
AI.
into the
Yeah,
EHR.
yeah. And
And it sounds like there's been multiple open source attempts, CDS hooks, open CDS, but it seems like it's still pretty costly to build and
it's
implement,
still
even
labor
with
intensive.
those.
It's still
Right,
labor intensive. So what you may have been getting to with the standardization of EHRs was the standardization of CDS. And standards are evolving, as you discussed, with hooks and, with open CDS, et cetera. But it's still labor intensive. It's still not point your EHR with an interface to this. It'll tell you what to do and it'll give you the orders that you need to accompany the decision support.
absolutely. And what do you recommend for, those small clinics that do not have, complex EHRs? They don't have the EHR support and analytics staff or funding. And even after paying, EHR integration and usage fees, there's a lot of other costs to maintain that
So
EHR.
we read a paper in our Informatics Journal Club, looking at small sites versus large sites with CDS and resources. And what you find is the small sites have more freedom, but they can do less because they don't have resources. The big sites have more resources, but they have less freedom because there's more governance and more stuff around larger money. I think as a small site, you're forced to partner either with a vendor or with a bigger institution. I don't think there's any magic solution. I think the government has tried to intervene, like in meaningful use with extension centers, which I think have had mixed results. And I think some people in the industry would go, what extension centers?
Mhm.
You know,
And-
where are the differences they made? They have made differences, but not uniformly.
And does the Public Policy Committee have any plans to propose legislation about CDS standardization?
I don't think the committee historically has proposed legislation or said this is something we need to go after. We have had some discussions on workforce about here are some things we'd like circulated because, our Congress and staffers and agencies have minds of their own. And our priorities may not be their priorities. And historically, the AMIA board, which his committee reports to, has not said, hey, why don't we try to convince them to do this? Because they're not waiting to be convinced. Our biggest asset is our science. And in fact, we're neutral. We're not trying to sell a product or a specific, professional line or something. And that's where I think our strength is. But I don't think we've ever come out and said, you need to do legislation around X
Do you think that
out of the blue.
as a group that AMIA and informaticists should be more proactive about lobbying for or proposing certain bills
I think
rather
you've
than
got-
waiting for Congress to
I think you've
to
got to
create
be
something?
careful. And first of all, AMIA has a very diverse membership. We have people who are educators, people who are researchers, some people who are practicing. And when we respond to things, we need to respond as informaticists, not as this is what I think as a physician, but now I can put the AMIA logo on my response and make it bigger. And I think we have found it challenging to do that. The other thing is if you're always proposing, suggesting you're going to get tuned out.
I would also offer, I think both of those are so true. I would also offer that based on AMIA's 501c3 status, our federal tax status, there are limitations to how we interact with the government. So we don't really lobby. We can educate the government. And like Joseph said, that's one of our best assets is we have this expertise and this neutrality. So we can educate them on issues. And certainly, talk about ideas that we think are helpful to advancing healthcare and things like that. But we wouldn't regularly propose legislation. We can interact
Okay.
with it, respond to it, things like that.
Do-
But
you
lobbying
think-
is not technically what we do.
Do you think we're at a disadvantage there as a field? Because some of the EHR vendor companies are investing thousands of dollars into lobbying.
I don't think we are. I don't think it's our strength. What are is a scientific organization that produces evidence, that educates, that thinks about these things. Our strength is not recommending specific products. And we have had and turned down, not from vendors, but attempts, just put your name on it, multiple organizations where we thought that that was the purpose of it. You have to be careful what you're lobbying for. Some of the organizations who say join us are really lobbying for themselves or lobbying for a role for themselves. And I think lobbying has a bad name for the reason I said it's money and access to advocate a particular thing. I think our strength is being neutral and selective.
Yeah.
Selective is going to get the wins here. Just lobbying is not. It just
And
yeah.
that's a question I've wondered about myself in my experience with the ACP Public Policy Committee. You know, when you see the lobbyists on Capitol Hill, and it kind of makes you wonder, like, a lot of these groups are for-profit groups, and it almost seems like nonprofit and for-profit groups are kind of on equal footing, and maybe they shouldn't be. And I just wanted to ask your opinion on that. I mean, physician groups, there may be some for-profit interests there, but there's also a lot of physicians who have nonprofit goals and intentions. And how can we kind of differentiate between that when we are for groups that are lobbying?
I think that's beyond the scope of AMIA and beyond the scope of the Public Policy Committee, and it's a broader discussion. It's a broader discussion of the role of lobbying of our government. I think all AMIA can do is advocate the science and advocate the education. So, for example, if we're advocating for clinical informatics fellows or nursing informaticists or degree, since we can actually show stuff they've done and differences they've made.
Yeah.
I think where AMIA could get into trouble is where we start just giving opinions because we're very accomplished people. So we're going to give you opinions on music and art. It's like, it's interesting, but it's irrelevant to the reason you'd want to hear from us.
Yeah, I can understand that. And another specific topic related question that I have, what do you think we can do as informatics professionals to improve technology for contact tracing for communicable diseases? Currently there, quarantine is not very effectively enforced in the US. And while some states do have penalties for individuals who do break quarantine, especially in the early part of the pandemic, or large businesses or events that are breaking those policies and causing outbreaks, what can we do with our technology to improve that?
I think this is an area AMIA can do actually a lot. And by that, I mean, I think we have a very large and we advocate and we can describe how public health can be connected, what successes we've had, where we've had wins. And I think AMIA has been active in that, where the federal government supports and funds public health. State by state, it's a lot harder. But at a federal level, and we have advocated for COVID, COVID based on the pandemic, et cetera. And I think that's an area where the science can really inform.
Okay, awesome. Well, thank you so much for your time today. I learned a lot, and I'm excited to stay informed, stay in the loop for the Public Policy Committee's work. And thank you so much.
Thank you. Thank you.
Thank you, Sanah.
And Reva, thank you too for joining.
Yeah, absolutely.
Sanah, we love your engagement, so we're
Oh, yeah,
always
we're
glad to
happy
talk to
to,
you.
we're happy to come back and talk to you. I wouldn't be chair at that point, but we're happy to discuss further
Thank you
as
so
things
much.
arise.
Yeah, I hope being involved in advocacy is that, for me personally, it reduces my burnout because I feel like I'm getting involved in the solution. So even, as a provider, contributing to an RFI, making our opinion known, even if there is no change in the outcome because of it, it does make you feel better, in my opinion.
And there's long-term and short-term change, right? Like, it may not be that there is an immediate sort of response to your advocacy, but over several months or several years, you might see, hey, that's the idea I actually wrote to them about. And, 2 years later, they're implementing it. So it's really hard to see in the short term, but I do believe, and this is why I work in this field, that the long-term change really does come to fruition.
And the priorities can change over time. Absolutely.
I think it's important to remember, and though scary too, that what one staffer told us of a senator now retired, and someone said, she said, well, you don't think that's accomplished much, but it took 10 years to get it done. And persistence, there's the famous quote, persistence is victory. Or persevering is victory, but I forget the exact quote and who said it at the moment. But it's important to input because at least you feel you've got a chance to let them hear you. Doesn't mean they wanted to, but at least they did. And I think the best way members can get involved is not, how can I join the Public Policy Committee and how soon? Because there's a limited number of people. It's a limited number of people because for us to be effective, it can't be a body of 100 people. But get involved with some of the RFIs, get involved with some of the RFPs. Sometimes Public Policy Committee puts out a request, we need expertise, we need help, or, the getting involved with those will do more, particularly for ASIF members.
Can the RFIs be anonymous as well?
No, I don't believe so. I do
Okay.
believe your name goes on them.
Do they? I thought it just says AMIA. I didn't think it
Oh,
said
they
all
do
the
for
people.
AMIA.
For
Yeah.
Because that's
Yes.
our name. But if an individual were to submit a response, there is a spot. There's a required
Oh.
field of putting some name.
Okay.
I suppose you could put, 1, 2, 3 in there, but they do ask for some identifying.
Okay, gotcha.
Yeah.
Awesome. Well, thanks so much. And I hope to continue my involvement in the future.
Yeah,
Well,
for
thank you for
sure.
the opportunity for
Thank
doing
you.
this podcast.
Thank
Definitely.
you.
Thank you.